Good morning, everyone, and welcome. I'm Sarah Cott, Senior Vice President of Programming at The Hill. Thank you all for joining us in person this morning, and thank you to everyone joining us online for our event, Pathways to Patient Affordability. I'd like to thank our sponsors, Pharma, for their support of this discussion. Today, we will be joined by members of Congress and stakeholders within the healthcare system to discuss what more can be done to ensure that all patients have access to affordable care. Before we get underway, a few housekeeping notes. If you're here with us in the room, please keep your cell phones on silent for the duration of the program. But we do encourage you to join the conversation on social media. You can follow us on Facebook, Twitter, and Instagram at The Hill Events, and we will be using the hashtag TheHillHealth. And with that, I am delighted to welcome Bob Cusack, Editor-in-Chief of The Hill, to the stage, who will be introducing our first panel.
Thanks, Sarah.
Thanks, Bob.
Good morning, everyone. Great to see everybody in person. It's great to be back doing in-person events. Let me introduce the panel. Lei Ding, Senior Vice President of Market Access and Commercial Capabilities at Astellas Pharma US. In the interest of transparency, note that Astellas is a member of Pharma, the sponsor of today's program. Douglas Hoey, the CEO of the National Community Pharmacists Association. Welcome. Kristin Bass, Chief Policy and External Affairs Officer at the Pharmaceutical Care Management Association, or PCMA. And Dr. Gary Puckrein, President and CEO of the National Minority Quality Forum and a regular at our events. Now, not everyone on the panel shares all the same views, but the spring is here, it's opening day, it's all good. We're gonna have a good policy discussion. Gary, I wanna start with you. Can you first tell me about, I mentioned in-person events. We're coming out of COVID-19. What has that effect been on the healthcare system, specifically on equity issues?
Well, certainly, first of all, thank you. I always love being part of these Hill events. We learned a lot during COVID, at least the consciousness was raised during COVID that we have significant inequities in our healthcare system. The mortality rates and hospitalization rates, and in fact, the infection rates in minority communities sort of documented that. And pleased to say that there's energy out there to do something about it. I'm not sure that we have a plan in mind yet on how we address these problems, but certainly I've been working in the health equity movement for years, and this is really the first time that collectively, when you look across health systems, everybody's talking about it, everybody's trying to think through it. So I think the world has changed, at least to that degree.
Kristin, tell us about PBMs, their role in drug pricing, and also PCMA's legislative priorities for this Congress.
Thanks for that question. So PBMs are the entities that are entrusted by health plan sponsors, so employers, federal government programs, to negotiate for lower drug costs. So our companies negotiate with pharmacies, who Doug represents. Our companies negotiate with drug manufacturers like Astellas. And the goal is to keep drug costs as low as possible and to really stretch the healthcare dollar, because we all know that health insurance premiums keep getting higher and higher and higher. And we want those healthcare dollars to go as broadly as possible. So our companies set up formularies in which they prefer drugs that are therapeutically equivalent to other drugs but are more cost effective. They really give people an incentive to take generic drugs, and so the generic rate is now 90% in terms of prescriptions that are filled. So our companies work very diligently to try and make sure that everybody, all of you who have insurance, are getting the best bang for your healthcare dollar when it comes to prescription drugs.
Lei, from the pharmaceutical drug industry perspective, how does drug pricing work, and how do you think it could work better?
So first of all, the drug pricing is a very, very complex problem, right? Or situation. There are many, many stakeholders in our entire healthcare ecosystem. You know, of course, patients are at the center of what we do here, right? So when you look at the entire ecosystem, there's, PBMs, payers, pharmacists, And then there's also providers and hospital systems. So it's quite complex system. So, from a pharmaceutical manufacturer's perspective, so first of all, we take risks to develop very innovative therapies, right, for patients. So that's really at the forefront of what we do every day, right? So from a pricing perspective, again, very, very complex. Again, we work with many, many stakeholders across the entire ecosystem to make sure patients have access to our products that we spend years and years and millions and billions of dollars to develop, make sure patients have access to those innovative therapy.
Doug, to you, what do you hear on the ground? And tell us about the pharmacy role in the healthcare system that Lei was just talking about, of many providers.
Yeah, as far as the pharmacy's role, we really see it as kind of a centerpiece. It's a place where patients see the pharmacy, their pharmacist more than any other healthcare provider, up to 12 to up to 35 times a year for some diabetes patients, as opposed to their primary care physician, which maybe only be 3 or 4 times a year. So the pharmacist can really be sort of the glue that holds it all together. We're stuck in the middle a lot of times. We have incredible reimbursement pressure from the insurer-owned PBMs. Our margins are razor thin, and it's really put the entire pharmacy ecosystem in a very fragile state. We're coming out of COVID. Pharmacies did over 300 million vaccinations. We helped the country get back on its feet, but coming out of the pandemic, pharmacies are in a very fragile state.
I want to ask you each about the, Gary, start with you, the IRA, the Inflation Reduction Act. A lot of healthcare provisions in there. I kind of want to go down the panel, but starting with you, what is the impact of that legislation, now law? It was, as you know, no Republicans voted for that, and some Republicans are taking aim now that they've taken back the House. But what's its impact, both short and long term?
So I have to answer that question with a deeper understanding of the Medicare and Medicaid program from the minority lens. CMS ran a quality improvement program starting in the 1990s. Lots of information out there that there were inequities in the Medicare program. That quality improvement program did nothing to change those inequities. Came up with pay for performance around 2005. Lots of energy put into pay for performance. No change in terms of the inequities in the system. Today we talk about value assessment and the value assessment programs. No change in the inequities. And so when we look at the IRA, the question that we have to ask is, so are we going to get better? Is this going to change anything for us? And what we haven't seen is a conversation about how does IRA actually provide access to patients? How do we get better? And so that's the lens that we're looking at. We're looking at it, and the measurements that we're using is patient outcomes. How do patients get better by this legislation? And that's the conversation that we want to have.
Kristin, your views on the IRA?
So there are a lot of pieces in the IRA. There is a restructure of the Medicare Part D benefit, which I think we're all looking forward to, because if we think about what will help patients, the out-of-pocket cost sharing is now going to be capped at $2,000. And I think we should all think that that is really helpful for Medicare beneficiaries. There are other parts of the IRA that I think we would prefer our companies continue to do. Our companies are very good at negotiating with drug manufacturers to get costs down. But the things that the IRA did not actually address are the pricing of drugs, which is something that the manufacturers get to set. The government's going to negotiate on a few things, but there still is a lot of work that can be done to improve the competition in the market, so that for the drugs that aren't being negotiated by the government, and again, we would prefer that none of them be, that PBMs would be able to bring competition to bear to really get the cost down for all of us, not just the Medicare beneficiaries.
Doug?
The IRA, as Kristin said, has a lot of pieces to it. One piece we like is the elimination of the cost sharing for vaccinations. But by and large, for pharmacies, I would say it's neutral to negative, and depending on how it's implemented. We feel like it really missed the mark as far as really lowering drug costs, which we would say would be to reform the PBMs and the health insurance plans, which are driving up higher costs of prescription drugs, and the IRA seems to completely ignore that part. The implementation for the negotiations for the MFPs, the maximum fair price, that will be key for pharmacies. That will be very important because pharmacies already have such thin margins that we can't sort of float the difference between of those negotiated prices to the consumers. So there's a lot of discussions as to how that will be implemented, and those are incredibly important. But overall, we feel like it, nice swing, but probably need to step back into the batter's box and see if they can make solid contact again.
Lei, what about you?
Yeah, so IRA took important steps to improve patient affordability, especially, there's the annual $2,000 out-of-pocket cap for Medicare patients. So that's the first piece. The second piece is that payment will be smoothed over on a 12-month basis. So that would improve the predictability of patients out of pocket. So those are the policies we have long supported. And as a matter of fact, I believe Astellas sponsored an event with the Hill a couple of years ago, right? Just to advocating for that piece of the policy. So it's great to see that has come into fruition. There's definitely more to be done, but this is a good starting point from a improving patient affordability perspective. However, the price setting part of the IRA also created challenges, right, for our future innovation, which potentially could have unintended and negative consequence to patient access to future innovation. So that's like our concern.
Lei, just a follow-up on coming out of COVID. I mean, it was record-breaking. I believe Ebola was the fastest vaccine before. Mm-hmm. That took 5 years, and the industry and government worked together to produce effective vaccines. It's become very political, and it was very interesting. I thought that Mitch McConnell, who's a polio survivor, he said he was just shocked that it became so political and that there were so many anti-vaxxers out there. But what are your takeaways from that research and development and the development of vaccines and what it means big picture going forward?
So that's really the vaccine part of the business, really outside of my expertise. Mm-hmm. But what I could say is patients should always be at the center of what we do, right? That's what we deliver, what we do every day. Mm-hmm.
Doug, as far as what you hear from there's people coming to the counter and trying to get care, and Lei was saying earlier that the healthcare system, which is true, and it's not going to change anytime soon, is enormously complex. What do you hear from customers, patients, that maybe Washington should hear more of?
I think Washington should hear that it's a very stressful experience for patients, because when that prescription is written by their prescriber, they're not sure what their experience is going to be for that medication. The pharmacist can talk to them about the medication and how it's going to work for them, how to use it most effectively and efficiently, and how to get the best health value from it. But as far as the payment system, they have no idea. It could be an inexpensive generic drug. Kristin mentioned that 90% of all of the prescriptions are generic, and generic prices have gotten lower and lower and lower. Generic prices, I sometimes refer to them as bubblegum drugs because they cost about the same as a pack of bubblegum. But yet patients don't know that, and they also have to navigate whether or not to use their health insurance, which used to be a no-brainer. Of course I'm going to use my health insurance. I have health insurance. I pay premiums for my health insurance. But now they see many stories where their health insurance, by using it, actually costs them more money than if they didn't use it. So that's a big chunk of patients. Then patients who are taking a brand drug or a specialty drug, they don't know how they're going to get access to that drug. Will there be a prior authorization? Will it be a high cost? Can they use a patient assistance program through one of the manufacturers? Will their insurance plan allow them to use that? Will their insurance plan try to steer them into one of the insurance plan's affiliated pharmacies, as the health insurers and PBMs have now acquired pharmacies? So it's very much an experience for the patient of, I don't know when and how I'm going to get my medication. And from that, we see patients just finally give up at some point and don't even take the medication because of the hassle factor. So it's a very stressful, it's not like it was 25 years ago where the prescriber wrote the prescription, patient walked over, handed it to the pharmacist, and 15 minutes later, presto, you got a prescription. It's not like that anymore, and I think our legislators in Congress need to understand it's hard, and it doesn't need to be so hard.
Kristin, can you talk about the role of generics?
Sure. I think ahead of that, I'd like to talk a little bit about some of the programs that our companies offer to try and make it easier for physicians to know that when they prescribe a drug, that it's on the formulary and what the cost will be, and then the patient knows what the cost will be, and whether there are things like prior authorization. And they're called real-time benefits tools. And all PBMs offer these tools, and they're available on electronic health records. And we are working to encourage more take-up of these tools by physicians. In terms of your question about generics, the beauty of generics, as we all know, is they're the same chemical entity as the reference brand product, and they do the same thing. And so everybody, most of us, if we're on some sort of a chronic med, inevitably, if it's a statin or something like that, we're going to be on a generic. Incredibly useful for creating headroom to then have the health system afford the innovations that Astellas and other companies are making. And so we really do, as PBMs, our companies set up their formularies to prefer generics, and the health plan sponsors who then decide what's the cost sharing going to be that's going to be assigned to that tier in the formulary will pick a tier and a cost that is affordable for the patient. One more thing that I'd like to talk a little bit about, and this gets to some of the patient concerns for people who are in high deductible plans, is that our companies pushed, as did probably a lot of other people in this room, to get the Treasury Department to change its regulations so that if you're in a high deductible plan and you're on a chronic medication, you use insulin, you can get that ahead of paying your deductible. So in essence, first dollar coverage for if your health plan sponsor chooses that program, and PBMs offer those programs to healthcare sponsors and really encourage them to take that up. So that's another avenue for trying to address some of the patient cost concerns at the pharmacy counter.
Leigh, as far as Astellas, how do you make drugs affordable, and also talk about the role of R&D?
Yeah, absolutely. I will address probably more the affordability part. So, first of all, we work with the stakeholders across the entire ecosystem, like PBMs, and then we also have the entire. We have lots of contract arrangement in place with the payers, the PBMs, the wholesalers, the specialty pharmacies, and the whole stakeholders to just make sure patients have access to our programs, to our products, and then in addition to the payer access part, we also have very comprehensive patient support programs, including some of the free drug programs, including the copay assistance, where that's applicable. So those are the things, as manufacturer, we're really working really hard to make sure patients have access to the innovation.
Gary, as far as the future of healthcare, and you've talked about this before, and you've been in healthcare a long time, there's a debate going on which is going to go into 2024 about Medicare and Social Security. They are not going to be revamped anytime soon. At some point, they're going to have to be revamped because they're both headed for bankruptcy. What do you think the policymakers, big picture, need to do 5, 10 years out? It's become so polarizing. 1997, Congress worked together, despite Bill Clinton and Newt Gingrich going at it on impeachment, passed the BBA 97, really extended life of Medicare. And that was a bipartisan bill. Only one member voted against it in the Ways and Means Committee. I don't see that bipartisanship happening anytime soon. Well, what are your thoughts?
So if you're talking to folks in the health equity movement, what they would say to you is that the system is fundamentally broken and has to be reimagined. That it is based on a rationing model, formularies, that discriminate, doesn't take into account ability to pay, disease intensity, and what is happening is that minority and underserved populations are being disadvantaged, severely disadvantaged in this system. So we have to have a new healthcare system. It has to be fundamentally based on patient outcomes. It's a journey that we have to take. It's not going to happen overnight. But I think the conversation that's going on, certainly in minority communities, and I use the word minority advisedly because 40% of the US population is minority. By the time we get to 2030, they're the majority. There's an emerging market in healthcare that you're not paying attention to. You're not hearing their voices. And what they're saying is the inequalities in the system cannot persist. This conversation is all about money, but we want to have a conversation about life. We want to have a conversation about protecting our families. And so I think there's a movement afoot that you may not be sensitive to that is saying that this system is fundamentally broken. It does not serve patients very well. I look at the Medicare program and the Medicaid program. 45% of Americans are in those programs, and they will be the majority program before it's over. And they don't work very well for our community. So I think there's a fight at hand here, and it's not about money, it's about life, and it's about how do we make sure that everybody who comes into the system gets optimal care, and that's the work of the health equity movement.
Just a quick follow-up on that. We were talking a little bit in the green room. There is no finish line when it comes to health disparities, but there's been more of a focus on it. Is that because of COVID? What do you attribute that to?
I think there are a couple of things going on. Certainly COVID and George Floyd brought attention to the inequities in the system. But what you also have to understand is that there are political voices out there that are now, you see it more down at the state level where the Medicaid programs are being pushed to look at outcomes. All of that's coming from voices in community that are looking at their outcomes and saying, I got to get better than this. When you look at diabetes, 40% of everybody in the country with diabetes is minority. 50% of everybody on dialysis is minority. I mean, you just look at the numbers. African Americans have the most cancer of anybody in the country, and they're not getting quality care. They're not surviving. And so I think it's rooted in those communities, down in local communities, bubbling up, and they're saying that this conversation isn't about us. This is not what we're asking the system to do. And I think that's what's at issue here, that we're not asking the right questions, we're not talking to patients, we're not understanding the change that's going on in American society.
I'm going to open it up to questions in about 5 minutes, so think about any questions you have. But Kristin, just on the big picture, I want to go down, you guys are all experts in healthcare. Just big picture, future of healthcare. Gary says we need a whole new system. How do you do that? You know, no one would create this system but it is what it is, and we have to live with it and obviously change it, but it's hard to totally change it.
It's such a good question, because if we think about how the trajectory of healthcare costs continues to rise. We spend a lot more money on healthcare in this country than other countries, and our outcomes are not better, they're worse. Some of the new therapies that are coming online are $3 million. And as we get more and more of those therapies, more and more of the population is going to need therapies that are going to be that costly. And so I think there's a sustainability question that we all grapple with. And so from our industry's perspective, we know that there will need to be a function in the healthcare system somewhere, regardless of how you reimagine it, that is going to have to do the tasks that our companies do. Somebody's going to have to negotiate with the pharmacies, somebody's going to have to negotiate with the drug manufacturers, somebody's going to have to do the claims processing and set up the formularies and figure out what the coverage is going to be, assuming we keep a private sector coverage model. And even if we don't, someone will still need to do that work. So as we reimagine what the healthcare system looks like, we still need to think about these functions that various players are doing. We're still going to need, obviously, pharmacies. Pharmacists are very important. We're going to need innovation on the drug side. It is a massive challenge, and we were talking a little bit backstage earlier about there was an economist, Stuart Altman, who was at Brandeis and who went to, he did a speech just before he retired, and he got up there and he said, I've been working in healthcare doing policy and making recommendations for 40 years, and I have failed. And so I think for all of us, our challenge is how do we all work together and continue to work to make the system function as best as it can. And that is what our companies do every day to try and bring costs down. And I think others in the system are doing their best to do their functions as well.
Doug, to you, and there are some, I mean, we have an aging population, we've got basically workforce issues because we're going to have a shortage of providers, already have in some areas. What do you think, big picture, on healthcare going forward, and what policymakers, both in the administration and the states and in Congress?
Well, kind of two phases of your question there. One on the shortage of primary care providers, and there is a huge growing shortage of primary care providers. We think pharmacists are ideally situated to help fill in some of those primary care gaps, and we saw that during the pandemic. We saw it in the early stages when many physician offices were closed. Pharmacists were still open, pharmacies were still open. So we think there's a big opportunity for pharmacists to be able to do more to help complement what's going on in primary care. As far as solving for healthcare, and we only have a few minutes here,
Right.
We need to, through our industry, we have to change the pharmacy payment model, and I think that also is a canary in the coal mine for the overall healthcare model. And by that, there are too many people in the middle. Probably 30 to 40% of costs go to people in the middle, people like PBMs, some of the health insurers. And the value that's added isn't necessarily 30 to 40%. We need to have more direct connections between providers and patients. The incentives are misaligned, and there's a lot of people in the country kind of feeding at the healthcare trough. To Gary's point, we have to reimagine our healthcare system, and I'm not sure who has the political appetite to do it, because it gores the ox of both sides of the aisle. But if we don't do it as a country, we're not going to be competitive internationally. We're already spending twice as much of our GDP compared to other countries. And to Kristin's point, our outcomes are middling. Mm-hmm. So we have to do something. It's going to take enormous change, but I think we start in the middle and extract some of that fat to get to care to patients, the cost of care to patients directly versus folks in the middle.
Lay, to you, the future of healthcare. Easy one.
Absolutely, that's a very easy problem to solve, right? So first of all, it's very, very complex, right? When you look at our entire healthcare ecosystem, it's like a gigantic Rubik's Cube, right? So one thing changes, everything else goes change and everything, right? So I think maybe we should really take a step back, right? Really to define what are we solving for, right? So, and then maybe define what are some of the common grounds, right? So what do we think is most critical to solve for, right? Is innovation important? Yes or no? Is patient affordability important? Yes or no? And then you can almost go from there, and there are lots of intelligent people in this whole industry and lots of intelligent people I'm sure we can find after we define really what we're solving for, right? And then try to align on, like, maybe there's some common grounds, and then let's find a solution there.
Mm-hmm. Bob, can I just
absolutely jump in.
Just finished a book called The Price We Pay by a physician in Johns Hopkins, Marty McCary, and that actually is a good starting point. He goes through the different, he's, like I said, a physician at Johns Hopkins, and he goes through the different ways that he's seen as a physician increase costs to healthcare, and comes up with some ideas on how we can bring more value to taxpayers and to patients. So just anyone in the book club, The Price We Pay, Marty, I don't get any endorsement for that. I've never met him, but.
Why don't I open up to questions in the audience? If you can just raise your hand and identify yourself and who you want to answer your question. Oh, right there.
Here's the microphone.
Oh, thank you. Hi, Adam Colborn, Academy of Managed Care Pharmacy. Thank you all for the insightful conversation this morning. I'm going to second the Price We Pay recommendation. AMCP bought a copy for all of our staff a couple of years ago and really liked it. But my question this morning is for Kristin. You talked a little bit about the real-time benefit tools, and I was wondering if you could talk more about the level of uptake that you're seeing from prescribers and whether there's been any resistance to it.
So what we understand is that Basically, some electronic health record manufacturers or providers make it easy to use a real-time benefits tool, and some don't. And so, as best we can tell, having spent a lot of time looking into why it isn't more heavily used, it appears as though the EHR folks could be making it easier for the docs to be able to use these things. And there's also some issues around interoperability and some other things that are pretty technical that I won't get into. Our hope is that it becomes second nature for folks, for prescribers to use, so that, again, you don't run into issues at the pharmacy counter. But it's a really good question, and it's a thorny issue, and one that lots of people behind the scenes are trying to work on.
Any other questions? Talk a little bit about transparency. I went to the dentist recently, and they said, would you like some toothpaste? It's really good toothpaste. And, you know, kind of woozy coming out of the chair. And I said, sure, I'll take the toothpaste. And then I got a bill for $35. And I returned the toothpaste because toothpaste should not be $35. But transparency, because we've talked about the complexity of healthcare, and patients don't understand it. I mean, I've covered healthcare forever, and it's so complicated. You have to kind of relearn things when you do panels like this. Gary, what do you think could be done there?
First of all, I'm not all that sure that healthcare is that complicated, right? I mean, the purpose of a healthcare system is to mitigate people's risk. You go to the hospital because you want them to mitigate your risk. You go to the doctor because you want them to mitigate your risk. You want to go to the pharmacy, you want them to mitigate your risk. We're making it complicated, right? We've built this system that refuses to acknowledge that its purpose is to mitigate patient risk, period, full stop. It's not a healthcare system if it's elevating patient risk. And what we see in the system, it's elevating patient risk. That's what the health disparities movement is trying to communicate, that our people are going into the healthcare system and it's making them sicker, right? And that's not healthcare. So, I mean, so the complexity is man-made. We can actually simplify this very, very quickly by getting focused on what is our purpose. Our purpose is to mitigate patient risk. Anybody who tells you that a healthcare system should be elevating a patient's risk is not talking to you about healthcare. And so that, we just simplify it and cut to the chase here. And then obviously what we need to do is understand how do we spend our money as we mitigate patient risk. Who's contributing value there? That's the question, right? And everybody has to belly up to the bar and say, here's my value, here's my transparency, here's what I'm bringing to the system, and we're measuring patient outcomes, right? CMS doesn't measure patient outcomes. There's no number. CMS is not saying I'm trying to reduce diabetes hospitalizations or cardiovascular events. It's not doing that. It's a dumb system insofar as patients is concerned. So I stand on the side to say that healthcare is not as complicated as we're trying to make it, right? Because we are putting things in place that have nothing to do with mitigating patient risk.
Kristin, to you on transparency, I mean, CMS over the years has done some things of trying to make more data available, having paper performance. How do you think that's going, and how do you think that could be improved?
So there are all kinds of requirements on all kinds of actors in the healthcare system to report pretty granular data. In our industry, our companies report data to 3 agencies, not just CMS, actually 4 because they added OPM. So the Treasury Department, the Labor Department, OPM, and CMS on the top 50 drugs, the aggregate amount of spending on those drugs, and additional data. I think from our perspective, what is most useful is what we call, and it's kind of a crappy phrase, but I'm going to say it anyway, actionable data. So what is it people really need in terms of transparency? They need actual transparency. So if you are a patient, what you need to know is how much is this, in our case drugs, but it would be the same for a doc or like if I was going to get imaging, how much is my cost sharing going to be at this exact point in my benefit under my insurance? That's what I need to know. And if I don't have insurance, then is there a place I can go look up what the cash price is? So that's what I need to know. That would be actionable for me. And our companies provide that on the drug side for all of their enrollees through the insurer or through the PBM directly. And then if I'm a doc, what I need to know is sort of the same thing for the patient sitting in front of me, which is, what is this patient's insurance? Is this drug that I would like to prescribe covered? And if it isn't, what is the alternative? Because every formulary has a therapeutic alternative that has been looked at by independent clinicians and determined that this is a good drug for this problem. And so from our perspective, what people need is what they need in the exact moment. And those tools, and we were talking about this earlier, we need to get those real-time benefits tools in more use. It would be good if the EHR providers didn't charge for their use, but set that aside for the moment. That's really actionable transparency, and that's the kind of thing we support. The other transparency, there's lots being reported. We have a two-pager that we'll put on our website, and you guys can see it, that lists all of the things PBMs are reporting on.
Doug, you know, when a lot of people go and pick up their medication, it's kind of roulette. They just don't know what the price is going to be. It just comes up and like, okay, well, I'm paying that. Are you seeing more patients demand transparency of why am I paying this much? And that's not an easy answer to provide.
They are, I don't know if they're demanding it or if they've just kind of acquiesced to the problem. Like, this is just how it is. Mm-hmm. But they don't like it.
Right.
But they're not sure how to solve for it. I mean, because it is so complex. It doesn't need to be, as Gary said, but it is. So, like, who do you get mad at? So oftentimes they get mad at the pharmacy because it's kind of a shoot the messenger kind of deal,
right.
Where we're having to say what their insurance plan is requiring them to pay. A lot of times we'll help them try to navigate the systems. There's pharmaceutical assistance programs that are often, increasingly, very helpful to help patients to be able to afford their medication, so we'll help them navigate that. But in many cases, they just don't know where to start. And they do get mad, but the pharma companies are sort of the companies they get mad at. That's like the conventional wisdom. I'm going to get mad at them. But they don't understand the role that the health insurance plans and the PBMs play in actually causing those drug prices to be so high. So it's frustrating for them because they're not sure where to start.
Like, you talk about those programs, and have they resonated with customers, and how do you see that going forward as far as transparency and that kind of thing?
Yeah, there's definitely more needs to be done from a transparency perspective. I think Doug mentioned, for example, there's this classic debate about list price versus net price versus what patients are paying, like out of pocket, with the deductibles, with the co-insurance. So it's very complex. There's definitely more needs to be done there. So a couple of things that, there are many solutions, right? So there are a couple of maybe easier solutions to think about as a starting point. The first one is, pharmaceutical companies are paying significant amount of rebates, right? So just to make sure patients, have access, have formulary. So maybe that part needs to be, how can we figure out a way to make sure patients actually benefit from that rebates, right? So that's one thing. The second thing is, Doug mentioned the copay assistance programs that many manufacturers have in place. How do we make sure that copay assistance actually count toward the deductibles of patients, right? So those are just a kind of starting point, in terms of continue to improve the patient affordability and some just ideas out there.
Gary, you mentioned that we have to make some major changes, and Americans are very focused on America. Are there international lessons to be learned from other countries, or are there state programs that can be a model? What do you see as a model for fixing things?
I think this is a problem that industrial societies face globally. I don't think America is unique in this conversation. Our science is making us smarter. Our capabilities to intervene is growing. Our ability to control health outcomes is growing exponentially. It costs money. It costs money to do that. And so some societies have decided that they'll just ration and push some folks off to the ice float and let them go, and they'll come up with nice means to do that. I think America can be different in this regard. I think that we can reimagine a healthcare system where we can actually provide quality care to everybody that comes through the front door. I think it'll take some time and energy to do. It's not going to happen overnight. We have a legacy healthcare system that, if you looked at the minority community, we would tell you that it's been discriminated against minorities since 1965, right, when the Medicare and Medicaid program came into existence. It's fully documented. So this is not unique. What we're saying is the moment has come to think differently, to give ourselves some space here so that we can reimagine the system, that we should reimagine HHS. We should give it some new orders and direction, because it is living on an old chassis that no longer works for us. And I realize that this sounds like a discordant note when you stand up and say, I actually want a healthcare system that is focused on patients and not money. Because when we look at the existing system, all it's doing is doing financial risk management. It's not doing patient risk management. And those are two very different things. One is not healthcare and the other is. And I think that's what we're striving for, is to move the needle. And we have the science to do it. We are very, very smart. We have great capabilities, and we're not using them. And the healthcare financing system is the drag on the system. It is the Luddite community, and we have to drag it into the 21st century, because by the time we get to 2050, we don't want to deal with diabetes. We don't want to deal with cancer. We want lupus under control, and I think we have the capabilities to do that. Any morning that we wake up, we could go do that, and that's where the energy should be.
Kristin, as far as this Congress is not expected, as I mentioned earlier, to do anything huge on healthcare, what are you watching at the government agency level, whether it's CMS or the implementation of IRA or FDA? What are some things on PCMA's radar that you're watching from the administration?
Well, actually, I kind of want to talk a little bit about Congress, because there are some very cool patent abuse bills that the Senate Judiciary Committee just approved that would help address some of the competition angles and actually get more competition onto the market faster, so that we could do what our companies do, setting aside Doug's suggestions otherwise, which is to use competition to bring costs down and get the rebates into the hands of the plan sponsors and the patients. So our hope is that they actually push those bills further.
And are they bipartisan?
Yes.
Okay. Doug, what do you want to see from this Congress?
I want to see action. Of course, we all say that as Americans, right? Someone mentioned in a conference I was at that this is the year of the PBMs, and there's a Senate finance hearing going on right now talking about PBMs. House E&C talked about them 2 days ago. I mean, there's a lot of talk. There's been some great bills. There's a great bill. There's HR 1613 that was just introduced, and I think Buddy Carter's going to be here in just not too long. So there's a lot of movement, or a lot of talk. But then I see key places where, like, for example, the President's State of the Union address, he talked about high drug prices. He didn't once mention insurance companies or PBMs. I don't know how he can have a conversation about high drug prices and reining them in without some reform to insurance companies and PBMs. So I'm concerned that there's a lot of Washington, D.C. speak, and not a movement towards actual action and reform that's going to lower drug costs, protect taxpayers, stimulate competition, help small business owners. So we need Congress. They are doing some good things. Senator Comer has an investigation of PBMs right now. The FTC is doing an investigation. But they need to take the words and turn them into meaningful action that, again, are going to lower drug costs for patients and protect taxpayers.
Leigh, do you see Congress acting in a bold fashion?
That's a great question. I think what we need is a holistic approach to solve this complex problem, right? There are many stakeholders in the entire ecosystem. So we need to really approach this from a very holistic way to really solve this problem. And you also mentioned the IRA implementation.
Yeah.
Again, how that's being implemented is going to be very, very important. There are lots of details yet to be defined in the entire implementation process. So Doug and I, we chatted before this session. Depends on the product flow, the money flow, how the system is going to work out. Is going to have significant impact to all the stakeholders, not just pharmaceutical manufacturers, but also to the payers, to the PBMs, to the pharmacists, to providers, to basically every single stakeholder in the entire ecosystem. And eventually, that will also have impact to patients, right? So that's going to be very important how exactly that's being implemented.
And that implementation will take years, right?
Exactly, yes.
And Kristin, what do you think? How many years are we talking about? I mean,
Well, they're going to roll it out.
you got to have regulations. You got to define the legislation, basically.
We should all feel very sorry for the CMS staff who is working probably 90 hours a week, every week, to try and get these regs done, because it is so complicated, and they are pushing out regs like nobody's business. And it gets implemented over a number of years, and so it's going to take a while to figure out what the real impact on the healthcare system is, especially given all of the different changes, right? Let's restructure the Medicare Part D benefit, and let's do this direct negotiation, and let's do some other things at the same time on the Medicare Advantage side, and it's going to be pretty interesting to see how it plays out. We just don't know.
Doug, you want to talk about implementation, what you're watching over the next several years of the IRA?
Well, the big thing is the negotiated prices. And as Leigh said, how will that be implemented?
Right.
Because if it's done the wrong way, from our one, we want to make sure those rebates actually get to the patient.
Right.
Which they don't right now. They're often 40% of all the drug costs go to rebates, and we're not sure exactly where they go. So that is important. It defeats the entire purpose of the IRA if that doesn't happen. Okay. So then how does it work? And from the pharmacy standpoint, the cash flow is super important, because if those rebates on their way to the patient, if the pharmacy has to kind of hold the bag until they get paid back, that will put pharmacies out of business. So the implementation is super important. As that expands over years, I mean, we're really looking at virtually all brand drugs being negotiated by the government. I mean, we tried to avoid that. That was attempted to be avoided, but it's here. So that implementation, I think, will be key. And these next few years for the entire pharmacy payment channel, we'll be looking back at this 10 years, 20 years from now and be saying what happened in 23, 24, and 25, we're still either enjoying or paying for 10 years from now.
Interesting. Well, we've run out of time for the panel. Please thank our excellent panelists. And I will, and no one got hurt, so it's all good. I'm going to hand it back to Sarah.